Very good evening to the chairperson and moderator, speakers, and all the participating doctors. I take this opportunity to welcome you all on behalf of Hetriva Healthcare. My name is Suvadeep Majumdar, a sales manager, East Hillian, dedicated to CNS. First of all, I thank you all for joining us today to discuss on two topics. The topic one is the role, the acetylcholine inhibitors in the management of BPSD, a forgotten role by Dr. Debanjan Banerjee, who is an eminent geriatric psychiatrist associated with Apollo Multispecialty Hospitals, Kolkata. And the topic two is the role will be by Dr. Sinjan Ghosh on the role of rivastigmine in PD and dementia with Lewy bodies, who is again a renowned behavioral neurologist associated with Narayana Hospital, Kolkata. And going through, sir, as you know about healthcare, we are the largest R&D organization with having 360-degree solution provider with more than 25 years of experience in multiple specialties, currently present in more than 126 plus countries worldwide, with almost 200 products across various therapeutic categories such as HIV, AIDS, oncology, cardiovascular, and the neurology, to mention a few. We have the distinction of bringing 4 biosimilar products to the market. Also, we have 36 plus state-of-the-art manufacturing facilities pioneering in quality and innovation. Now, today we have with us Dr. Amitabha Ghosh, eminent neurologist from Kolkata, currently associated with Apollo Multispecialty Hospitals as Director and HOD of Department of Neurology, as a chairperson and moderator for today's session. His name itself is nothing too much to introduce. He is an institution in himself, especially with in dementia. So, sir, I request you to please share your experience and to discuss more on the subjects. I hand over the session to you, sir.
Thank you, Shubhodeep, and welcome everybody. I hope we will have a very exciting session today. We have two excellent speakers. We have Dr. Debanjan Banerjee, who will be starting off, and then Dr. Sinjan Ghosh. Dr. Debanjan's topic will be on acetylcholine receptor cholinesterase inhibitors in the management of BPSD, and he's titled his talk as a forgotten role. Very interesting because see, ultimately, with all the exciting new developments and the new drugs which have already come in the West, and some of them will be coming, I'm sure, as biosimilar products as well in India in the next few years. The foundational symptomatic treatment of these dementias still remain unchanged, and you have the acetylcholinesterase inhibitors, you have memantine, and we continue to use that in appropriate patients. I think sometimes we overuse that, and I always warn my doctor colleagues that you have no business to prescribe memantine in patients with MCI or even with mild dementia. But they have their roles in different parts of the in different stages of dementia. Rivastigmine, of course, is available, as you know, in various forms, and we've been very successfully using them in many diseases, including Alzheimer's disease, as well as in Lewy body disease. And Dr. Sinjan Ghosh will be speaking on the role of rivastigmine in Parkinson's disease and dementia with Lewy bodies. So I'm sure you will have a very exciting evening today, and I once again welcome you all. And I will now hand over to Dr. Debanjan so that he can start off with his topic. Debanjan Banerjee, please.
Yeah, thank you, sir. Very good evening to everyone present here and all the participants and audience. So I'll go ahead and I'll be sharing the slides now.
Debanjan, you can introduce yourself.
Right. So thank you once again. Thanks to the organizing team here. Thanks, Mr. Shubhadeep, for having me here. As already mentioned, I am a psychiatrist. My special interest is in geriatric psychiatry, and I work in Apollo multispecialty hospitals. I have basically completed my post graduation in psychiatry and my postdoc from NIMHANS, National Institute of Mental Health and Neurosciences, Bangalore. And as always, it's always a pleasure to share the forum with Dr. Sinjan, who is both a friend and a colleague. So, thank you, sir, for the kind introduction of the topic. And what going to do in the next 15 minutes or so is just take you through um, a well-established but yet a forgotten role of acetylcholinesterase inhibitors, the classical medication yet known as the anti-dementia drugs, mainly in behavioral symptoms of dementia. Now, we know that we are already a bit late, so I'll try to keep it as brief as possible. If I hope my slides are changing and I am audible.
Yes.
Right. So if any point of time you see that they are stuck or you're not able to hear me, just feel free to, just inform me about that. Well, so this is kind of a quintessential slide that accompanies every presentation about dementia. We are almost in a population boom, and the number of dementia individuals living with dementia is supposed to increase rapidly. The latest estimate is 1 in 3 seconds. So it becomes very important to discuss the behavioral manifestations. Now, out of the many different domains, we as psychiatrists, of course, and in general, individuals who deal with dementia care are very perplexed and concerned about behavioral and psychological symptoms of dementia. So they are a group of symptoms which usually and very frequently accompany different type of dementias based on the neuropathology, the phenotype. They are different in different, in different individuals, but largely they are categorized in these groups: aggression or agitation, psychotic symptoms like hallucinations, delusions, misidentification, psychomotor agitation, where a person resists care, is not willing to eat, dress, repetitive actions, perseveration, depressive symptoms, lack of drive, hopelessness, anxiety, sadness, mania or euphoria, or apathy, a very, very challenging symptom domain where a person is extremely withdrawn with lack of interest. When we talk about behavioral symptoms, something very important is that they don't occur in isolation or in vacuum. So, when we are talking about an individual, somebody having dementia doesn't necessarily mean that he or she will not be having other illnesses. There are several physical and environmental triggers which can increase behavioral symptoms. This is important in any presentation that talks about behavioral symptoms, because when we speak about medicines to reduce these complaints, we also need to be mindful about what's going on in the surroundings. So, sundowning or change of environment, metabolic parameters, it can be hypoglycemia, hyperglycemia, hyponatremia, or hypokalemia, multiple medications, including beta blockers, anticholinergic agents, uh, polypharmacy, many of our psychotropic medications, pain, constipation, dehydration, infection. Many of these can trigger these behavioral symptoms that we spoke about. So, apart from what we discussed, there can be nighttime behaviors, wandering movements, carbohydrate craving, increased sugar craving, which many of you might have seen with people who suffer from especially frontal symptoms or frontal type of dementias, and self neglect is another such domain. Why are we discussing behavioral symptoms here? Because they are a very, very frequent accompaniment, up to 80-90%. They're more common in non-Alzheimer's dementias, more challenging in that aspect. They contribute a significant amount to caregiver burden and elder abuse. So, because It's not always overt, but many people cannot manage these symptoms and end up in probably neglecting the patients. Now, it's very common that when there is an individual with dementia in a household, when he or she is forgetting, it's often considered to be a normal part of aging. Forgetfulness is often normalized, and that person may not be brought to medical attention. But the moment he or she is agitated, throwing things, screaming, yelling, suspicious, that's something which catches the caregiver's attention and hospital visits very commonly. So, BPSD or behavioral symptoms are something which often make the patients come to your clinic. Now, let's face this question. I'm sure that we have a diverse group of audiences. I am not very sure if they can communicate with us, Shubhadeep. Can they?
Yeah, they can communicate, but through questions only, because it is going live to YouTube. So from there, they cannot. They will be
Okay.
putting comments at
Perfect.
the end of the session. They will have a question
So
answer
no
session.
issues. I will just keep it as a question then. Feel free to type your responses that if you are facing an individual with behavioral symptoms, will you be using antipsychotics, the classic antipsychotics? Why I'm asking this question will be relevant in the next few slides. So I will probably at the end of my presentation go back to the responses. Feel free to mention yes or no. And for those of you who are mentioning no, I just request you to also mention the reason why you wouldn't choose antipsychotics. Now, a very important area. FDA in 2008 issued a blanket black box warning for all types of antipsychotics that it increases the risk of death. And this needs to be there in a label as a boxed warning and to be mentioned whenever any antipsychotic is prescribed to a person with dementia. This is based on a large network meta-analysis and a combination of randomized placebo-controlled trials, and both second and first generation have an equal risk. So the cardiac risk and the all-cause mortality for antipsychotic use is high. However, if we randomly look at prescriptions, even that includes everybody, there is a tendency to use significant number of antipsychotics in managing behavioral symptoms. This is one of the latest and a very comprehensive review of how BPSD needs to be managed. And as one statement, one liner, reviewing every single evidence, it's very clear that non pharmacological measures, managing situational triggers, training the caregiver, trying to identify the trigger and dealing with it is always the first line in management of behavioral symptoms. When agitation happens, the immediate answer is not to give a risperidone, olanzapine, amisulpride, quetiapine, but to also understand what's happening in the surroundings. There may be hunger, fatigue, there may be sensory deprivation, loss of vision or hearing, medication change, multiple prescriptions, loneliness, social isolation, worsening of this cognitive functions post evening, that is classic sundowning, problems in change of caregivers, feeling that a person's privacy or modesty is being violated, perceived threats, and of course, associated depressive symptoms. Uh, Dr. Amitabha, sir, Dr. Sinjan, myself, all of us work with the Alzheimer's Related Disorder Society of India. And one thing that we keep reiterating while talking about dementia is that the person who has it is always alive. The illness never damages the identity. So we need to be mindful of what's happening to the person. This flowchart may be a little crowded, but what I essentially wanted to highlight here is that this paper, the comprehensive review, it very clearly mentions that if the first line non-pharmacological management fails, we need to use antipsychotic, if at all, in a combination with an already existing acetylcholinesterase inhibitor or memantine. And it needs to be a symptom domain based treatment, not a blanket treatment. So if there is predominant depressive symptoms, SSRIs. If agitation is predominant, antipsychotic. If insomnia is predominant, either a very low dose sedating antipsychotic or trazodone. We all know that antipsychotics have several adverse effects in dementia. not only the all-cause mortality, but drowsiness, gait disturbances, weight gain, cardiac risk, and so on. Why did I start talking about antipsychotics? Because as psychiatrists, we have this, in our disposal. Even neurologists, psychiatrists, all of us prescribe antipsychotics because we need an immediate relief for an agitation, or the family members get extremely distressed. But often, and that's why I have mentioned this in my title, the forgotten role is not highlighted. We forget that acetylcholinesterase inhibitors themselves, especially rivastigmine, I'll come to that later, has a good propensity to deal with behavioral symptoms. So there was a meta-analysis quite time back in 2008 where the impact of cholinesterase inhibitors was seen. And this, to quote from the paper, is that the dual acetylcholinesterase inhibitor rivastigmine has shown to have potential advantages over other ones like donepezil and galantamine. Rivastigmine appears to be effective across the range of dementia severity, mild to severe, across the spectrum of dementia. So not only severity, also Alzheimer's, non-Alzheimer's, especially with DLBD, Lewy body, and Parkinson's associated dementia, with Dr. Sinjan will be speaking soon after. It also appears to have a disease modifying potential. I work with the IPA. So this is the official journal of the IPA. This came out in 2009. This was a systematic review of all the randomized placebo-controlled trials of donepezil, rivastigmine, and galantamine in dealing with BPSD symptoms. 14 studies were identified, 9 of donepezil, 3 of galantamine, only 2 of rivastigmine. The median study treatment length was 24 weeks. Most studies used NPI as a behavioral outcome. What was interesting to see was that a head-to-head comparison could not be done because the number of study and sample size was too less to establish the power. But even though the effect sizes were moderate, the quality of life improvement and caregiver burden reduction was significant. Now, we are more interested in these rather than change in certain symptomatic scores, and that's what matters. Apathy, we know that can be a very, very challenging symptom. It is not depression. Depression, a person feels low. Apathy is lack of feeling. It is characterized by emotional neutrality. Often assessed by apathy evaluation scale, it's something which is very common when the medial or the dorsolateral prefrontal cortex is affected, especially in frontotemporal dementias, Parkinson's plus and Parkinson's associated dementia also happens in Alzheimer's. There is no FDA approved drug, but it can lead to significant caregiver burden, because imagine when a person is not emotionally caring for the family anymore, the personality changes, and that leads to a significant disturbances in the family dynamics. So in this review, what was seen is that out of 52 interventional studies, methylphenidate to some extent, low dose, olanzapine, citalopram, which is a SSRI again, memantine, cholinesterase inhibitors do have some role on apathy, especially in FTD and DLB related apathy and PD related apathy. Rivastigmine has a definite role and better role than other medications. This was published in Frontiers in 2020. It spoke about all the evidence and what guidelines recommend in future. So acetylcholinesterase inhibitors, these are the domains that they target. They target depressive symptoms, the sundowning and the typical nocturnal confusion, agitation. You may often hear the person getting up in the middle of the night, going to searching for sweets, opening fridge, randomly taking sweets. It's a typical frontal symptom again, and apathy, as we already discussed. Let's have a quick look at the guidelines. What do they say? We'll look at a couple of guidelines. The NICE guideline in 2018 clearly mentions that a structured assessment is necessary to find out the environmental cause of behavior and to understand the distress. Random prescribing any medication, especially antipsychotics, is a strict no according to NICE. It clearly mentions that a personalized psychosocial regime is necessary as a first line. When do we use medications? We use antipsychotics when a person is at a risk of harming themselves. They may wander off get lost, fall down somewhere, or when they are experiencing agitation or hallucinations. And we have to mention to the family members that this is an off-label use. For dementia with Lewy bodies or Parkinson's, NICE clearly mentions that rivastigmine has an edge above the other. And a very important statement in the guideline: optimize the dose of acetylcholinesterase inhibitor before adding antipsychotics. And at every 3 months to 6 months interval, you need to document the progress. And if the person is doing well, you need to de-prescribe antipsychotics and stop. De-prescribing is probably the most important practice to reduce pill burden in dementia. What about APA? APA mentions the role of acetylcholinesterase inhibitors after you carefully evaluate medical, psychiatric, and environmental problems. Best is when medicines are used together with psychosocial interventions, and it mentions two important things. There may be a possible risk of worsening of agitation, especially in non-Alzheimer's dementia with donepezil, and a transdermal preparation of rivastigmine may be better for nighttime behaviors. To quote APA, on the basis of good evidence, acetylcholinesterase inhibitors are recommended in treatment of behavioral issues. They have shown modest improvement in behavioral symptoms in general, but have improved caregiver distress and quality of life. Let's have a quick look at rivastigmine. It has definite improved efficacy and tolerability with transdermal patch, as Amitabh sir was already mentioning. It is preferred over other acetylcholinesterase inhibitors. However, remember, we do not have any head-to-head trials. It is based on clinical anecdotes and secondary analysis from larger studies. Better in depressive symptoms, agitation, Lewy body, Parkinson's, Parky plus, reduces the need of antipsychotics, which is most important factor because we have seen the associated mortality risk. And studies show that dual inhibition of acetyl and butyl cholinesterase and brain region selectivity, which has come through fMRI and SPECT studies, with preferential inhibition of the G1 isoform of acetylcholinesterase, rivastigmine. This particular property of rivastigmine makes it probably better in treatment of BPSD. Just before we kind of conclude this session, we have spoken about acetylcholinesterase inhibitors. We need to remember their role not only as a cognition enhancer, as a protector, as a medication that delays dementia, but also something that controls behavioral symptoms. At the same time, we need to keep in mind patient factors, environmental factors, as we discussed before. Over-under stimulation, caregiver change, training of caregiver are equally important. We call this commonly the DART approach. We first describe and find out the context of the behavior, then we analyze what is leading to it, then we treat using both pharmacological, non-pharmacological measures, training the home caregivers and the paid caregivers, and finally, at every step, we have to evaluate, be it medicines or not, whatever I am doing, is it improving the person's quality of life? So these will be my take-home messages. The classic medications, in spite of all the exotic medicines that are coming, I should specifically mention here that we now have pimavanserin, 34 mg, which is a specific 5-HT1A inverse agonist. And that is very well known for managing psychotic symptoms and behavioral problems in individuals with Parkinson's disease, dementia or not. So yes, pimavanserin is available in India now and we can use it. But in spite of all the new medications, we should not forget the role of our classic old acetylcholinesterase inhibitors, especially rivastigmine, which possibly has an advantage in non-Alzheimer's and Parkinson's disease. They are specifically better for agitation, apathy, and sundowning. However, the side effects may also be worsening of sleep, a persistent headache, and if a person is having florid psychotic symptoms, then we may think of reducing the dose of acetylcholinesterases. Ultimately, psychosocial intervention stays as the first line measure, and every person is an individualized choice. So there is no one formula that works for all. I'd like to mention that the eye support manual is freely available online in multiple languages and is one of the fantastic sources to share with caregivers to deal with behavioral problems. This manual, if anybody is interested, I can share it. This is the IPA BPSD manual for clinicians and nurses guide. And that would be all from my side. I'd like to reiterate the role of our classic old acetylcholinesterase inhibitors in BPSD. Any queries beyond the webinar, feel free to mail me. Thank you.
Thank you, Debanjan. That was a absolutely lovely talk, very, very lucid. I don't see any questions coming.
Sir,
No,
questions will come after the session, sir. After the
after
both
this.
speakers, means,
Okay.
both the speakers are off, then the questions will come.
So then probably you have to handle that. Okay. We will then move on to Dr. Sinjan Ghosh, who will be talking about rivastigmine's role in PD and in dementia with Lewy bodies. Over to Dr. Sinjan. Sinjan, please introduce yourself and then start.
Thank you very much, Dr. Amitabha, sir. And at the outset, I would like to thank Mr. Majumdar and Hetero Health and the whole organizing team for this wonderful initiative. So, and a wonderful talk by my friend and colleague, Dr. Debanjan. I really enjoyed it. So, without further ado, I would like to share my screen. I hope it's visible and I'm audible.
Yes.
Okay. Thank you very much. So I'll be focusing my talk on the role of rivastigmine in dementia with Lewy bodies and Parkinson's disease with dementia. So dementia with Lewy bodies is a form of dementia in the elderly, the commonest neurodegenerative dementia being Alzheimer's disease. So the characteristic features of dementia with Lewy bodies are fluctuating cognitive impairment. Family members do say that patients have some good days and some bad days. So on good days, it's very difficult to say that the patient is having any problem on. So that is one of the challenging aspects of this condition. So they do have attention problems, they have visual hallucinations. They may be distressing, may not be distressing. They can see animals and people walking around who are actually not there. So they do have Parkinsonism, which is mostly atypical Parkinsonism. Uh, Typical Parkinsonism is asymmetric. This has got symmetric tremors and early gait difficulties and other behavioral issues. So in neuropsychiatric features, visual hallucination is the hallmark of this condition, but they do have other conditions such as delusions, agitation, aggression, etc. As Dr. Debanjan mentioned, and they do have sleep disorders such as REM sleep behavior disorders. They might talk in their sleep, they might kick, punch as if they are acting out from their dreams. So, as we've discussed, that rivastigmine acts both as a butyryl cholinesterase inhibitor as well as acetylcholinesterase inhibitors, which gives it an extra edge over donepezil, which acts as only an acetylcholinesterase inhibitors. So many deficits in cholinergic neurotransmission are seen in different parts of the brain in a patient having Lewy body dementia. Therefore, drugs enhancing central cholinergic function represent a rationally based therapeutic approach to this disorder. So I'll be going over some of the landmark trials, landmark studies on the role of rivastigmine in patients with DLB and Parkinson's disease with dementia. So this was published in Lancet in the year 2000 by McKeith et al. So this was a placebo-controlled double-blind multicentric study done on 120 patients from UK, Spain, and Italy. Individuals were given like slowly titrated up to 12 milligram of rivastigmine daily in two divided doses, or there was a placebo group as well. So this was given for 20 weeks and followed by 3 weeks of rest. And what they did was at 12 weeks, 20 weeks, and 23 weeks, they did a cognitive assessment and as well as neuropsychological testing. and patients underwent close medical and lab safety analysis. So, interestingly, what they found were patients taking rivastigmine were significantly less apathetic and anxious, and they had fewer delusions and hallucinations as compared to the placebo group. So, almost twice as many as patients on rivastigmine than on placebo showed a 30% improvement from baseline. So, rivastigmine at a dose range of 6 to 12 milligram. It depends from individual to individual. So it's prudent to slowly titrate the dose, and it seems safe and well tolerated. But the dilemma lies in what Dr. Debanjan was just mentioning, antipsychotics. They have a black box warning, especially in elderly individuals, and they have cardiac risk factors as well. So, what these antipsychotics do for controlling these behavioral issues, antipsychotics are prescribed, but they have detrimental effects on swallowing or deglutition, which puts them at a risk of aspiration pneumonia. They have problems with their gait or walking, so they can have recurrent falls and fractures. So, the impact of this medication is huge. We have to remember that in somebody who has multiple medical conditions and is on polypharmacy, we have to be extremely judicious in selecting our medication. And not only that, dementia with Lewy bodies, these patients, these individuals have severe neuroleptic sensitivity. So they might end up with neuroleptic malignant syndrome or NMS as well, which is a life threatening condition. Now, the next dilemma is to treat Parkinsonism, we give dopamine agonists. But at a certain point in time, in advanced stages, when we have to increase the doses, there will be hallucinations and confusion. It's evident. So, what do we do now? It's basically striking a balance between controlling hallucinations and delusions and keeping the motor symptoms of Parkinsonism at bay. So, this study results suggests that cholinesterase inhibitors could be a more rational choice of treatment for Lewy body dementia patients than neuroleptics, both on efficacy as well as safety basis. Now, let's look at this image. So, what do we see here? So, these are some of the risk factors. As we know, aging is definitely a major risk factor, genetic predispositions, vulnerability of cholinergic neurons, and environmental factors such as inflammation and stress. What they do, the cumulative effects eventually lead to death of central cholinergic neurons. So now, if we look at this portion above and the top left corner, so there's a death of cholinergic neurons, which leads to relieving the brake on inflammation. So it results in further exacerbation of inflammation, which leads to neuronal death. So mostly the basal forebrain cholinergic system and the brainstem, they are affected. So there's a complex interplay of the neurotransmitters as well as the brain circuitry, which eventually affects the hippocampus, which is the seat of our short-term memory, that gets affected. Now, extensive deficits in neocortical cholinergic function occur in Lewy body dementia as well. So probably secondary to presynaptic depletion in brainstem and basal forebrain cholinergic nuclei, with more preservation of postsynaptic mechanisms than seen in Alzheimer's disease. So these differences in pathophysiology could explain why, in comparison with beneficial effects seen in Alzheimer's disease, patients with dementia showed even greater improvement in cognition and neuropsychiatric symptoms when treated with rivastigmine, especially in cases of DLB. So a procholinergic treatment might theoretically be predicted to exacerbate Parkinsonism. So we've learned from years together that you give dopaminergic agonists, dopaminergic agents, and you give anticholinergics. So what happens is that when anticholinergics are given, so in tremor predominant Parkinsonism, they might have beneficial effects, but in individuals who have problems with their gait and in advanced stages who do have cognitive problems, anticholinergics might have detrimental effects, right? For the obvious reasons, as I mentioned, because acetylcholine is very important for our memory formation. So a procholinergic treatment, what would come to our mind? A procholinergic treatment would exacerbate the motor symptoms of Parkinsonism, but fortunately, in practice, this does not happen commonly. So this probably indicates the complex interactions of non-muscarinic nicotinic cholinergic receptor mechanisms in the control of basal ganglia function. The profile of treatment responsive target symptoms needs to be fully characterized. What we are treating, what are we targeting? And then, as Dr. Debanjan mentioned, periodically we have to assess the patients for their cognitive fluctuation, activities of daily living, and the quality of life. And I would like to add to that, definitely caregiver burden. So improving quality of life of the patients and mitigating the caregiver burden. That's essential. So coming to another landmark study by McKeith et al. So here they mention that DLB patients experiencing visual hallucination showed a clear and significant response to rivastigmine in terms of improved attentional function compared with non-hallucinators. So individuals who had less hallucinations as compared to others who had DLB, so they had poorer response as compared to those who had hallucinations. So what they inferred was that greater cortical cholinergic deficits have been reported in hallucinations versus non-hallucinations in both retrospectively. So evidently, rivastigmine would work better in hallucinators. So this was another study of rivastigmine in treatment of Parkinsonian psychosis. So rivastigmine significantly reduced neuropsychiatric disturbance in advanced Parkinsonism, and improvements were recorded by the neuropsychiatric inventory, which is another tool to objectively measure the behavioral symptoms, their improvement or their deterioration. So caregiver distress consequent to the patient's neuropsychiatric or behavioral problems was also markedly ameliorated by the drug. So as an indirect effect, definitely. And in addition, overall cognitive performance was significantly enhanced due to its pro-cognitive effects. Now, most of the patients were maintained on rivastigmine following the study and have not shown signs of significant deterioration over 70 weeks of subsequent detailed follow-up. So they followed the patients up and saw there was significant persistent improvement as well. So association of hallucinations with vivid dreams and sleep fragmentation suggests that REM sleep disturbances may be central. So hallucinations during wakefulness are known to occur in subjects with prolonged REM sleep deprivation or rapid eye movement sleep deprivation. So success of rivastigmine in relieving hallucinosis may reflect its ability to enhance REM sleep. So this is interesting because as we know, what our understanding is that during REM sleep, we dream, our memory is consolidated. So whenever somebody is deprived of REM sleep, so they are missing out or missing out on their sleep hours. So they're REM sleep deprived, and what happens is that it affects their memory and their cognitive functioning. So any medication that enhances the REM sleep would have a beneficial effect. Now, the use of cholinesterase inhibitors provides a new approach to a difficult clinical problem. And uh, in many cases, we might actually not prescribe them antipsychotics, which has got a black box warning. Now, this was a RESPOND trial where they have noted the role of rivastigmine on gait instability in patients with Parkinson's disease, and they had noted that with increase and improvement in attention, what happened is that their gait improved as well. So dysexecutive syndrome in Parkinson's disease adds to the problem of gait initiation and gait maintenance velocity, and they might have a risk of falls. So an underlying loss of cholinergic function contributes to freezing and other gait changes, postural instability and cognitive dysfunction. So cognitive dysfunction we know, but look at its effect on the gait and postural instability. So evidently, rivastigmine would have a role in these motor features as well. And as we know that pedunculopontine nucleus has been implicated in gait disorders in various lesional studies as well. So overall, rivastigmine has a beneficial effect on gait and balance. So as I was mentioning, the gain might or might not be mediated via improved cognition, specifically improved attention to compensate for impaired gait resulting from striatal dopaminergic loss or via direct effect on gait. So it might be an indirect effect or a direct effect. When the person becomes more attentive, the chances of falling is less. So the future analysis that is to be done is whether this acts as um, ameliorating agent for loss of attention or whether it refocuses attentional priority to gait and movement control. Now, this was another study published in NEJM, another reputed journal, in 2004, where they've noted the role of rivastigmine for dementia with Parkinson's disease. So, in various studies, it has been proven over the years that rivastigmine has got a moderate to significant role. And there was a significant, statistically and clinically significant improvement in terms of behavioral features. But they had nausea, vomiting, and tremor as side effects. So gastrointestinal side effects are there. So that's when the patch is helpful, right? So the take home points would be rivastigmine has a role in managing hallucinations in DLB and PDD. They can be a rational alternative to antipsychotics and better adverse effect profile. The gastrointestinal side effects can be mitigated by using patch formulations, and compliance can be ensured in advanced dementia patients by using a patch because they tend to refuse medications, they spit out medications, they might have paranoid delusions that somebody is trying to poison them. So, in those cases, patches do help. So, with this, I would like to end my talk and I'm happy to answer any questions. Thank you so much. Over to you, Dr. Amitabha Ghosh, sir. Thank you.
Thank you, Sinjan. Again, one very detailed description of rivastigmine and its role in these disorders. So we have now come to the end of two very lovely talks, and I still don't think there are any questions.
Yeah. Are there any
Uh,
questions? Sir, I just get back. Actually, questions will directly come to you. Actually, in your inbox, it should come. I just let me check it out, sir. If there are any questions.
Yeah.
Mr. Jayant, are there any questions from there? I think there is. Sir, there is a question from Dr. J.K. Solanki from Ranchi. Does rivastigmine subdermal is available? Acha, okay, that is for his.
That's for
We
your,
use,
that's for
yeah,
you
yeah.
guys.
We usually use donepezil 5 and memantine
10
10 milligram with olanzapine for sleep and
and
VH
behavioral
disturbances.
disturbances. So you will have to answer. I don't know. I'm sure rivastigmine is available in Ranchi. I think rivastigmine has been
There is
available
a
in
question, sir.
India.
There is a continued question. We usually use donepezil 5 and memantine 10 milligram
I
with
know
olanzapine for
that is
sleep.
because he's saying rivastigmine may not be available. First of all, it is not subdermal. It's kind of a patch which is kind of, well, I suppose it is subdermal absorption, but the rivastigmine patch is available across India for many years. I think you need to go and check with some of the bigger pharmacies, or you may want to go to one of the bigger hospitals in Ranchi and check that out. It should be available. Um, um, for behavioral disturbance, a combination of donepezil and memantine is probably not something you. I don't think that's something you would have meant. I think you wanted to treat the dementia, and you're talking of the behavioral disturbance. Olanzapine for sleep, I would kind of uh, not quite encourage you to do that. I think there are much safer, if I may, sleeping medicines which you can give in patients with dementia, like melatonin, which is kind of a natural hormonal product of the brain which helps in sleep. That is available. You can give melatonin. Um, uh, yeah, I mean these are best. Olanzapine and other antipsychotics are best left for specific purposes. And as you have heard from two speakers, they have their risks involved as well. From
Sir,
Dr. The Dr. Solanki, Oh, Dr. Debanjan has replied something, I think, there as well. Yes, exactly. He's already replied. Yeah, there's another question. I'm interested in how dementia is differentiated from Lewy body, vascular dementia, and Alzheimer's disease. Well, I'll leave that to Dr. Sinjan to come back to it again. He did that beautifully the other day.
Sir, shall I try and answer it?
Yes.
Yeah. So that's a very important question, but it's a talk in itself. Basically, there are various differentiating points, but just to clarify, dementia is an umbrella term, and Alzheimer's disease is the commonest form of dementia. We have other types of dementia, such as dementia with Lewy bodies that I mentioned, the features I have mentioned, especially Parkinsonian features, atypical Parkinsonism. They have fluctuating cognitive function, and they have visual hallucinations and REM sleep behavior disorder. That is, they act out in their dreams. Vascular dementia is usually temporarily associated with a stroke, either in a strategic area or multiple small strokes over the time can have certain deficits. They can have speech problems and motor deficits, but along with that, they can have cognitive deficits as well, like executive dysfunction, attentional problems, and also some behavioral symptoms. And frontotemporal dementia affects usually the frontal and temporal lobe. They do have a lack of filter. They use explicit words. They can have loss of empathy as or sympathy. They can have sweet cravings and also other behavioral issues. So basically, there are various differentiating features. You have to remember that a detailed history and clinical examination is a must, and then you go for neuroimaging and try and
Yes. So Dr. Solanki, this is all of these are dementias, the ones you've mentioned. They're all different types of dementias. And each one, as Dr. Shinjon has said, has different characteristics, and that will be diagnosed by the neurologists or psychiatrists who especially work on these disorders. So that is how it goes, because they have different treatments and they've got different projections in the future. So you can't kind of lump them up as one disease and treat them. There are a lot of things you need to consider before even starting treatment in these patients. Dr. Jitendra Verma has said, would you use lecanemab or aducanumab? Are they helpful in BPSD? Dr. Debanjan has replied that. So I will just add to that reply that lecanemab, aducanumab, aducanumab has been totally withdrawn from the market. From January 2024, aducanumab, the company started to withdraw aducanumab. Initially, they left it only for patients who were on the aducanumab research trials as extension of those trials. They continue to use, that is called open labeled. But from 1st November this year, aducanumab has totally been removed, and you will not get aducanumab. In fact, you wouldn't get aducanumab anywhere from January, but from now, even the research people who participate in research are not going to get that. There are two drugs, one lecanemab, you have correctly said, and the other is donanemab. These two drugs are the only two drugs that are available as anti-amyloid therapy to modify disease. But these drugs are not drugs which have been designed to work in BPSD. They have only been designed, mind you, most of these BPSDs that Dr. Debanjan spoke to you about, some of them are found subtly, like anxiety or late onset depression and things like that. You can see them very early in the course of the disease, but many of them are in the later, the moderate to severe stages of dementia. Now, these drugs have been only tried and they're only approved in patients with early symptomatic Alzheimer's disease. So these are patients, A, they have to have Alzheimer's disease proven by biomarker diagnosis. So brain amyloid PET, there's a type of scan doing that. Then there's a CSF. amyloid and tau and things like that, which can be tested. You have to prove it is Alzheimer's disease beyond doubt. And then you have to show that they're early symptomatic. In other words, they have either mild cognitive impairment or a mild dementia. And there are scores and ways of doing that. You can't do that in your clinic just like that. So it needs, additional stuff to be done. It is only in those patients that by removing the amyloid, that they have shown quite a modest but significant degree of cognitive recovery. But so if a patient has a mild, late onset anxiety or a late onset depression, which kind of is a feature of early Alzheimer's disease, that can happen. Sometimes suspiciousness can be a feature of early Alzheimer's disease. In those patients, if we prove Alzheimer's disease, then it might work, but not in general for BPSD. I hope I've answered the question.
I think these are the two questions, and no more questions are there. Mr. Jain, there are any questions? Any more questions?
No.
Okay, thank you.
So thank you very much. Wonderful
Sir,
session. I really enjoyed it, and I was pressed for time, but I'm very glad to know that we've not only finished in good time, but also finished very well in good time with both the speakers presenting their talks, and we had a short but sweet but very informative discussion. So I thank Debanjan, I thank Sinjan, and I thank all of you really who are there, Shubhodeep, and I can't see Jayant. So take care and good night.
so thank you, sir. From on behalf of Hetero, sir, I thank you and Dr. Debanjan Banerjee and Dr. Sinjan Ghosh for having this time and within your busy schedule to get this time out of and to share your insight into this. Thank you,
Thank
sir. We look forward to your again, sir, participation and your help whenever we are going to organize this kind of
you.
informative and
Thank
this
you.
medical session, sir.
Thank
Thank
you.
you. Good night, sir.
Thank
Thank
Sir,
you, sir. Good night.
thanks everyone. Thank you. Thank you, Shinjan. See you.
Thank you,
Thank you.
Debanjan. Thank you, sir. Bye.
Bye. Yeah, Mr. Jain, thank you.
Yes, thank you. Bye.
Yeah, bye.
Yeah.